Hello, and welcome everyone to the Myositis Association's Ask the Expert New Mexico Neuro Necrotic Myositis edition. It's on my script says NM, which for me stands for New Mexico. So we're glad you're with us today. I'm Debbie Armstrong, and I'm honored to be your host for today's session. And for those of you joining for the first time, I'm broadcasting from, as I said, from beautiful New Mexico. And we'd love to know where you're from, where you're tuning in from, and feel free to share your location in the chat. Just be sure your message is set to everyone by using the drop down at the bottom of the chat box. And since 1993, the Myositis Association has worked to improve the lives of those affected by myositis through research, advocacy, education, and support. We envision a world without myositis, and every day we work toward the vision together with you. Now I'll hand it over to Rachel to take care of some housekeeping for us, and then we'll get started. Rachel.
I am here. Can you see my slides?
Yes.
Yes. Okay, let me get them in presentation mode. Welcome everyone. Thank you, Debbie, for hosting today, and thank you, Prateek, for being here, sharing your expertise. I just want to let the audience know for all of our myositis resources, events, and our Myositis Awareness Month toolkit, you can find that on our website, myositis.org. Before we get started, TMA does not give medical advice, and we ask every speaker to disclose any potential conflicts at the start of their presentation. This webinar is being recorded and will be available on TMA's YouTube channel next month. Please put any questions you have in the QA box. Any questions put in the chat box may be missed. Applicable questions submitted when you registered are being entered into the Q&A by TMA staff. No need to submit again. Questions that do not pertain specifically to this webinar may be answered in future programming. Feel free to use the chat like you guys are to let us know where you're joining from. And then we've got a quick poll real quick. Let me launch it. Okay, you should see this on your screen. What have you done to raise awareness this month, or you are planning to do? You've got these options: sharing your story or a fact on social media, having a conversation with someone who doesn't know about myositis, organizing a first pitch, or submitting a proclamation request or something similar. Of course, donating to TMA is always appreciated. Wore awareness gear or decorated your space. Ask your rep to co-sponsor House Resolution 277. And if you have other, please share other in the chat. We have about half of the audience has participated, so I'm going to go ahead and share the results. And you guys are brilliant. You're keeping it simple. It doesn't have to be a heavy lift to raise myositis awareness. 72% of you have chosen to have a conversation about myositis with a friend, coworker, or family member who didn't know about myositis. That could be your dentist. It could be anybody. We've got a couple of first pitch and Proc 50 volunteers on the call, but the coming in second is 33% of sharing your story on social media. And we really appreciate all that you do to help us in this endeavor. All right, let's go to the next slide. We want you to be aware of all of our groups. We have roughly 50 groups, 33 regional groups, and then 9 affinity groups, and that does not equal 50, but I am bringing up new ones all the time. We just had brand new TMA Cincinnati Tri-State that had their first meeting this past weekend, so we're going to get to the 50 soon. And this is about asking a representative to co-sponsor the House resolution that we previously mentioned in the poll. The link will be in the chat. And then, of course, we are working towards raising funds this month during the Myositis Awareness Month. And I just created, just this morning, my own campaign to ask my personal family and friends to donate. And you are free to do that as well. All right, it's back to you.
Thank you. Thank you, Rachel. Now I'm thrilled to introduce our expert for today, Dr. Prateek Gandiga. Dr. Gandiga is committed to the ideal that compassionate, collaborative, patient-centered care is the core of rheumatology. While he enjoys helping patients with a variety of rheumatologic conditions, he has a special interest in autoimmune muscle diseases and myositis, including dermatomyositis, polymyositis, antisynthetase syndrome, and immune-mediated necrotizing myositis. In addition to patient care activities, he serves in multiple national and local professional societies and medical education efforts. He has also completed clinical research training through the Competitive National Institutes of Health, CRTP program, and educator training through the Selective Macy Medical Educators Training Program. In his free time, he enjoys being outdoors, discovering good things to eat, and making up silly songs to sing to his family and their gooberhead rescue dog. Dr. Gandiga, welcome. I, like others on the call, have necrotizing myositis, and we really are looking forward to your presentation.
Thank you
And
for
then
that.
if I can ask folks to put questions, we have some pre-submitted questions, but additional questions you can put in the chat. And once Dr. Gandiga is done with his presentation, we'll go to questions. Thank you.
Thank you very much for that very lovely welcome. And thank you guys for hosting this. I think that it really is a subject that's near and dear to my heart. And I really appreciate all the efforts that TMA has been making over a long, long history in terms of raising both awareness and advocacy for myositis, really supporting our mission to try and find effective treatments and cures for these diseases. And I really appreciate all of you showing up to honestly, half of the job is just coming, getting information, spreading that information to other people, other providers, making sure that we're aware and kind of talking about these conversations. So happy Myositis Month to all of you. And I'm looking forward to talking with you. I'm going to go ahead and share some slides so that we can get started. Can you see the slides on your screen?
Yes, yes, we can see them.
So my thought is that I really want the session to be all about you guys, and honestly, so we're going to go through slides very quickly. I have no agenda. If we want to hop off the slides and kind of spend more time asking questions, that's fine. But really, the bulk of this should be whatever you guys want to make out of it. So thank you again for having me this morning. Just in terms of some paperwork and things like that, I do have disclosures that I've been investigator, safety, and safety officer for multiple clinical trials, both sponsored by governmental associations as well as the industry. And I've received some honoraria from some sponsorship organizations, including the NIH, the HHMI, as well as worked with Janssen Pharmaceuticals and Kazar in terms of designing some of their myositis trials, none of which are directly relevant to the studies. Again, today's talk is geared towards patients, so thought that we would keep some of the background information simple and accessible. So sorry to any docs or healthcare professionals that are on the call. And as a disclosure, I think myositis is the most important autoimmune disease. I mean, that's my personal expert opinion, and so I might be a little bit biased. But again, thank you guys for all that you do for trying to raise awareness of this disease. So plan for today, like I said, let's start, just 10, 15 minutes. We'll do some basic background about immune-mediated necrotizing myositis. And to kind of get the interaction starting, I'll talk about some frequent asked questions, but really, honestly, that should be no more than 10, 15 minutes. And let's spend the most of our time talking about whatever you want to talk about or ask questions about. So please feel free to put those questions in the chat. All right, so I think one of the problems in terms of how confusing the subject area is that it's really new, and honestly, it kind of changes a lot, and that's a good thing, and it's also a bad thing. So back in the 1950s and 1970s, when myositis was first described, there were only two flavors that you could have. You could either have this classic polymyositis with muscle involvement, or you could have that plus rashes, and that was dermatomyositis, and that was the way that we started thinking about it. But what gets really confusing is, especially over the last 5, 10 the years, we've really recognized that not everyone's the same, and there's actually a lot of different subcategories and subcategories that we really should start taking into account when we're trying to deal with patients and think about their disease and how best to approach helping them out. And so when we think about adult idiopathic inflammatory myopathy, which we shorthand and call myositis or autoimmune myositis, clinically, there's a couple of big categories that we really think about these days. And so one is dermatomyositis and its subtypes. Another one is polymyositis and its subtypes. And there's some debate as to how many subtypes or how big a category that is. We think about inclusion body myositis, antisynthetase syndrome, and this overlap myositis where you can have more than one type of autoimmune disease. And then one of the other big categories is what we're talking about today and really focusing on, which is immune-mediated necrotizing myopathy, which is also abbreviated IMNM. It's also known as necrotizing autoimmune myopathy, NAM, and that's part of the confusion is that we call things multiple different ways. So I'll probably be talking mostly about IMNM or NAM, and so if you get confused, please just let me know and ask me to use one term more consistently. So what exactly does IMNM mean? Well, when we created this category and thought about this category, we really grouped it together based on the characteristics of their muscle biopsy in this particular type of patient. And so in this particular type of patient, when you do a muscle biopsy, the muscle damage and necrosis seems out of proportion to the lymphocyte-mediated inflammation. There can still be inflammatory infiltrates and inflammatory cells in there, but it really looks like it's out of proportion to what we see in other types of autoimmune myositis. So what exactly do I mean by that? Because that gets really confusing, right? Necrotizing is in the name. What does necrosis mean? Well, if we start with the word necrosis, honestly, it's a pretty simple definition. It just means that you have premature cell death in living tissues. This is typically due to injury or disease. It's not specific. If you have ischemia or poor blood flow, you have necrosis. If you have infection, you have necrosis. In this particular case, we're talking about autoimmune diseases where one part of the immune system gets confused and attacks normal healthy tissue, thinking it's foreign bacteria, and causes necrosis there. So if you think back to basic biology class, I know it's been a long time for many of us, myself included, but when we think about cells and we think about muscle tissue, if you cut a piece of muscle across the side and you kind of look at it on end, well, that muscle is going to have bundles of different types of muscle fibers that are going to be grouped together, and there's going to be connective tissue, sort of like saran wrap that's surrounding these different bundles as the way the muscle is organized. So when we look at it underneath a microscope, muscle tissue normally looks like this. And so you can see that it kind of looks like hexagonal shapes, and you can kind of see in the schematic towards the bottom that it looks like polygons. There's little blue dots that are there, or the nucleus of the cell on the outside of the cell, and there may be some blood vessels or connective tissue, but it's a pretty plain field. So compare that to what we see with most types of myositis. And you see how, those hexagonal shapes are kind of a little bit more spread out. There's more connective tissue, more of a rounded shape. And what you can see is these little blue dots, and those little blue dots are inflammatory cells. Inflammatory cells are parts of the immune system, and there's a lot of different flavors of them, including things you may hear about like neutrophils or lymphocytes. The lymphocytes have different flavors as well. But those cells kind of come in, they cause quote unquote inflammation, and they cause necrosis, which is the cell death. And you can see those necrotic tissue that ended up being those cells that are starting to get smaller, kind of losing some of their color and some of their insider thing. And that's what we see with most types of myositis. So what happens if we biopsy somebody that has IMNM or NAM, depending on which term you prefer? Well, you can kind of compare the two side by side, and you still see those necrotic muscle fibers with kind of losing their shape and kind of dying off. But comparing it to the other type of myositis, you see very few inflammatory cells. And that's kind of how we originally decided to group these people together. And so that's kind of where we started with. And then we realized that this group of people tend to share certain characteristics. As if that wasn't confusing enough, later on, we ended up deciding and realizing that INMN can actually be multiple different subtypes. And so we actually realized that there are three big categories we should think of when we see people in the clinic. part of it is Lisa Christine at Hopkins. You guys may know of her. I always laugh because she always tells people to know their antibody. So antibodies are proteins in your bloodstream that react with normal healthy tissue. And I think of them sort of like knowing what color jacket somebody's wearing. So if I'm trying to figure out if they're a fan of this team or this team, knowing what color jacket they're wearing on game day might actually help me figure that out. And so there are patients in INMN that have anti-HMGCR antibodies. Those are one subtype that we think about. One subtype has anti-SRP antibodies, and one subtype ends up having none of those myositis antibodies. And those are the three big groups. It gets a little bit sloppier than that. There are some other myositis antibodies that you can end up having that still have the same pattern on biopsy inconsistently. Sometimes they present like this, or sometimes they present like this. There's other antibodies like this anti-mitochondrial antibody. We're wondering if maybe we should start considering that a little bit more. But really, when you're talking about it, talking with your doctors about it, these are the three main groups that you should know about, and these are the groupings that you should know which one you are if you happen to have this particular disease. All right, so what does IMNM look like when you talk about the clinical characteristics? I say are pretty common for most people. So unlike other autoimmune diseases where you tend to see it in younger people, like usually in their 20s or 30s or things like that, people with INMN tend to be a little bit older, 40s to 60s. I fall in that age range, so I'm not going to say it's old, but it's a little bit older. It tends to be a little bit more women, but it tends to be a little bit more balanced than we see in other types of myositis or autoimmune disease, where it's about half and half. And it is considered a rare disease because of how many people around the world have it, but that turns out to be roughly about 6,000 to 7,000 people in the US. So even though you sometimes feel like you're alone, there are 6,000 to 7,000 other people that are just like you. When we see people in clinic, most people tend to have this characteristic pattern of weakness where they have relatively quick onset of weakness in certain muscles. When I say relatively quick, I mean that typically we're talking about weeks to months in terms of the inflammation and their weakness developing. Rarely we can see it happen over the course of days, but that's quick compared to other types of myositis where we may see it lingering over the course of a couple of months or things like that. And there are characteristic muscle involvement. So they tend to be the muscles in the shoulder girdle. They tend to be muscles in the thigh area. So people with INMN oftentimes have trouble doing things like brushing their teeth or reaching for things, or trouble standing up from toilet seats or low seats or walking upstairs because of that weakness. Sometimes people with this disease can have weakness of their swallowing muscles, or sometimes they can have weakness of their neck or their back muscles, but that tends to be a little bit less common. Sometimes you can have other muscles of involvement as well, and we'll talk about that in a second. Some people with INMN can also have myalgia or muscle pain or muscle achiness. And so when we teach med students, we teach them that myositis tends to be painless progressive weakness. And what we mean by painless doesn't mean that you're not allowed to have muscle pain, but it means that the weakness tends to be the predominant feature, and that the pain is kind of a side effect or a consequence of that, rather than other diseases where it's really the pain that's the prominent feature and things of that nature. So like I mentioned, in addition to kind of these peripheral muscle involvement, because of the swallowing muscle involvement, some people can have difficulty swallowing, or they may notice that they're coughing after they're eating or drinking. Sometimes, rarely, you can have problems with those muscles that end up expanding your chest wall or helping your lungs expand with your breathing, and we worry about that a lot. We also worry about, in some cases, people can have muscle involvement of the heart muscles, and it can cause weakness of the squeeze function of their heart or cardiomyopathy. And again, those are things that we look at for most people. It's uncommon for this disease to actually have direct inflammation of the lungs or interstitial lung disease, which we do see in other types of myositis, but it does happen sometimes. And other types of myositis you may see have a stronger association with developing cancer, either at time of the diagnosis or later on down the road. And that does happen with INMN, especially the seronegative types, or sometimes even the HMGCR types, but that tends to be much less common or much less likely. So this is kind of the broad picture when I see somebody and I'm kind of trying to think, what's the stereotypical presentation that someone is going to be like? It usually looks like this. Okay, so what causes INMN? That's a really good question. And one of the questions people always ask me is, what could I have done differently? How could I have avoided this? And honestly, most commonly, it's just dumb luck, unfortunately. And I hate to say it that way, but it's really not something that you did wrong or something that you should have avoided. We do know that these anti-HMGCR antibodies and the SRP antibodies are pathogenic. And so it seems like they actually cause disease once your body develops those antibodies. And there may be a genetic predisposition. So if certain people are there, even though it's uncommon for people that have myositis to have other family members that have autoimmune disease or myositis. One thing that you will see is that about 70 to 85% of the people have previously been treated with statin medicines. Statins are medicines that we use oftentimes for cholesterol or preventing heart attacks because of atherosclerosis or things like that. The flip side of it, I should say, is that statin medicines are really useful medications. They're really helpful with mortality and morbidity, and causing INMN is a really, really rare side effect of those. It's about 0.002% of people that are on statins end up developing this disease, but there is that risk and that association. And so, I put up pictures of some mushrooms and red yeast rice on the slide to remind me that statins come not just in the pills that we prescribe, but in certain types of mushrooms and mushroom supplements or red yeast rice. So just because something's natural doesn't mean that it doesn't have side effects or it's not a medication. And it's also to help remind me that patients with this type of disease typically shouldn't receive statins in the future, including both prescription ones as well as these quote unquote natural or herbal supplements, because it can actually trigger or worsen their disease and cause it to flare as well. And again, that's a case by case basis, but that's a general kind of rule that we think about. All right, so how is this disease diagnosed? And when I explain it to patients, I usually tell them that in my mind, I think of it sort of like a court case where you're trying to say, all right, what's all the evidence that supports this diagnosis or argues that it's there versus all the evidence that goes against it? And is there enough evidence to kind of convict this diagnosis and say, this is what we think should be there? And sometimes that diagnosis or that amount of evidence changes over time, and we have to revisit or think about the diagnosis. Well, what kind of evidence can we think about to try and help us with that? Well, one is actually history and physical exam. And I know it's not as sexy as some of the other things, but honestly, 90% or 95% of the way we make diagnoses in rheumatology is actually talking to people and doing their exam and kind of saying, all right, how did things change over time? How are they today, and how has that evolved? Oftentimes we'll do some labs that kind of give us another data point or give us some more information, and that's another piece of evidence that plays into it. Sometimes those two things are enough to make this diagnosis, especially if you have a really typical story. Sometimes we say, all right, well, I think it's enough to think about it, but maybe we need some more evidence. And so oftentimes common other tests that you may see us ending up requesting are EMGs. EMGs use really fine needles. They look almost like acupuncture needles to look at the electrical activity of the muscles and how they squeeze and how they talk to the nerves. And oftentimes there are patterns that are suggestive of myopathy or myositis. Sometimes we'll think about doing MRIs, and MRIs are kind of non-specific, but sometimes you can see that swelling and that fluid and that inflammation. And sometimes the pattern of that and how much it's there kind of helps support or refute against the diagnosis. And in some cases, we do suggest doing a muscle biopsy where we take a sample of tissue to look at underneath the microscope. And no one test or one of these things is in and of itself to make the diagnosis, but oftentimes it's a combination of these for any particular person that really helps us make or kind of confirm the diagnosis that we're thinking about. And what tests we need really depends on the clinical history and the situation. All right, so then how do we typically treat this? And one of the big themes is that everyone's a little bit different, but medications or things like that you may see as commonly used is oftentimes we use things like glucocorticoids. Sometimes we call them steroids. And that's oftentimes used because they're really non-specific. They affect the immune system in a lot of different ways, and they tend to act relatively quickly. We hate those in the long term because oftentimes they're the ones that are associated with the most long-term side effects. So oftentimes we're thinking about using them temporarily while we're trying to get something else on board. Something else comes in a lot of different forms. Oftentimes you'll see us use medications like methotrexate, azathioprine, mycophenolate. Those are called conventional just because they've been around for a while. Doesn't mean that they're bad or good or anything like that. It just means it's been there for a while. Often, it sounds like a couple of you have been treated with intravenous immunoglobulin or IVIG, where we take people that have donated blood. We purify antibodies or immunoglobulins from their bloodstream. We mix that together with about 10,000 other people that have donated their proteins, and then we end up giving that back as a medication. And that's really effective for certain types of myositis, including certain types or certain people with INMN. Sometimes we'll use things like rituximab or Rituxan, and we put that under the category of B cell depletion. B cells are a part of the immune system, and there are other medications or other treatments we use that target that part of the immune system, but Rituxan is a pretty common one. And then you'll see us use other medications as well, and they include things like JAK inhibitors, cyclophosphamide, clinical trials, etc. And the one thing to know is that as of right now, unfortunately, there's no FDA-approved treatment for immune-mediated necrotizing myositis, but a lot of this is informed by either expert opinion, clinical trials that we have done, or kind of the expertise that we have in terms of what has been shown in these case series or other patients that have had this particular type of disease. Ultimately, unfortunately, the only way to know how well a medication is going to work or how well it's going to be tolerated is oftentimes just to try it and try to see what can we do with that and how someone responds. I think it's also really important to think about non-medication interventions as being an important part of your treatment. That includes things like physical therapy and exercise. That includes avoiding things that are going to be muscle toxins, so common things being things like alcohol or things like that. We mentioned avoiding statin medications for most patients. And again, that's a case-by-case basis of the risks versus the benefit, but almost invariably we'll say that the risks aren't worth it. And making sure you have adequate nutrition. And again, that's case-by-case basis based on your other medical issues and things like that, but making sure that you're getting plenty of fruits and vegetables and as much protein as your physician and your other team members think that you should be getting for that particular condition. It's not unusual to need combinations of different medications or to try both these things. And again, it's important to do both the non-medication as well as the medication options. And like I said, unfortunately, the state of the science and one of the things that's frustrating for both patients and doctors is that we're not at the state now where I can see somebody and be like, aha, I know exactly what's going to make you feel better and what's going to tolerate it. I can kind of make some information that helps me kind of make some assumptions or guesses about that, but oftentimes we have to work together and see how things work. All right, so this is kind of the summary section I have for the medical students in terms of if you ended up having to run off to the bathroom or falling asleep, here's what you missed. And so basically the take-home messages is that INMN, immune-mediated necrotizing myositis, is a subgroup of autoimmune myositis. We group them together because of their characteristic muscle involvement and their muscle biopsy findings, but they tend to have some clinical characteristics that they all share compared to the other myositis. That there are three main subtypes, the anti-SRP, the anti-HMGCR, and the seronegative types, that we diagnose it based on weighing the evidence from the history, the exam, labs, and other tests, and that we treat it with a tailored combination of medication and non-medication interventions. And that, again, just most people should not take statins in the future, including those natural statins or those supplements. So if that's the consideration, really should be talking with whoever your rheumatologist or neurologist or the primary person treating your myositis is before you start those things. Okay, so a couple of quick frequently asked questions for you guys, just to kind of get us started in terms of the interaction. So first question is, what is the best medicine for INMN? Does anyone have any thoughts? See a couple of things coming up in the chat and whatnot. Very cool. So I think that, honestly, it's a little bit of a trick question. And the trick question is, it's not what's the best medicine, but rather the question is, what's the best medicine for me at this time? And that's really an individualized type of a thing. When you're working with your doctor or your team, really there's a lot of considerations that go into that, including how bad and where is this autoimmune activity? How is it manifesting? What medications have you been tried on in the past for the myositis and how did you respond to them? There is some influence in terms of the subtype of what kind of immune-mediated necrotizing myositis it is, just because we can make generalizations and say these types of patients tend to respond better to this, even though that's, again, a generalization and not for everyone. We think about the logistics of the medicines and other medications you may be taking, as well as your other medical problems. We call those comorbidities that kind of come into it. And then again, we want to make sure your preferences are coming into play when we're talking about this, and it really should be a two-way conversation with your care team. Okay. Another frequent question that I get is, well, why am I feeling weak? So if I think about all the things that come into weakness with patients that have immune-mediated necrotizing myositis, you can kind of roughly categorize them into 5 big things. One is the autoimmune disease causing muscle inflammation and that active autoimmune disease. One is the fact that you can imagine that building on fire, even after you get the fire out, you have to go back in, you have to clean things up and whatnot. And so there is muscle deconditioning, either because of disuse or because of the inflammation. Unfortunately, these medications, again, we always would weighing the risk of side effects and benefits, including things like high-dose steroids. Sometimes they can cause weakness. And again, just like the building on fire, unfortunately, depending on the person, sometimes some of that inflammation can cause scarring and fatty atrophy that doesn't necessarily come back or doesn't necessarily regenerate. There are other stuff that can play into it as well in terms of things like nutritional profile, neurological issues, etc. So all of those things are kind of coming back together. And the insider tip or the insider trick is that both for an individual patient and an individual snapshot in time, it's really hard to kind of say, all right, well, which one of these things is the one that's driving it? You can imagine that if it's mostly the muscle inflammation, I may need to use more immune suppression medicines. But if it's the muscle inflammation is under good control and it's kind of side effects or deconditioning, I may need to take a different approach. So every single time that you're seeing your physician, they're going to be saying, all right, what percentage is coming from what things and what things do we need to address to try and help address the weakness? And just because you're weak doesn't necessarily mean that you may need more immune suppression or vice versa. And so we want to really kind of keep that in mind. All right, last question for you is, can patients with INMN exercise, or is that going to damage their muscles? What do you guys think? So lots of responses coming in from the chat, lots of good things. Very cool. So the answer is yes, please. And so this really is a real change in the disease that we've thought about over the last 5 years or things like that. Before we used to say, all right, well, the muscles are strained. Why are you going to strain them more? You're going to end up damaging them. And it turns out we were absolutely wrong. There's been some really great work, especially some of my colleagues in Sweden, that have shown that this exercise helps with the deconditioning and the medication side effects, but it also helps regulate the immune system, sort of like some of these medications do. And so it is an integral part of what we should be doing, and exercising early is really helpful for a lot of our patients. There are a couple of big caveats with this. Number one is you need to talk with your doctor and your care team to kind of try and figure out, all right, what can I do? How should I do it? It's a prescription just like anything else. It really needs to be tailored for your needs, not just in general, but at that moment in time. And that need is going to change over time. We really want to kind of think about both improving strength, but also improving endurance. You can imagine with that deconditioning and these other things that can happen. It's not just doing something once, but also kind of doing it multiple times over the course of the day. And oftentimes we'll consider having someone see a physical therapist or an occupational therapist or both to really kind of customize and guide their regimen along with the other things. I think knowing your limits is really important as well. As a general rule, for most patients, it's the frequency that really makes a big difference. So if someone tells me, hey, I spent 15 hours in the gym on Saturday and I was wiped out for the rest of the week and I didn't do anything for the rest of the week, I would say, that's awesome. I'm glad that you're trying to incorporate that non-medication part of it, but it usually doesn't count. Usually we want kind of a little bit less more frequently. I will also say that you should use caution in terms of your exercise around testing time for things like blood work or the MRIs or the EMGs, mainly because by its very nature, if you're exercising, you're straining the muscles, and that's going to cause those muscles to have a little bit of breakdown, and then they're going to grow back a little bit stronger. And so that's not necessarily dangerous or things like that, but sometimes it can influence things, and it can make someone's muscle enzymes in their blood work look a little bit higher, or make their MRI or the EMG or other things look a little bit off, and then I won't know, is that because of the exercise or is that because of the autoimmune disease? In general, if you want to know more about this, there are a lot of great things out there, including I'll make a plug for the TMA actually made a really helpful series of videos a couple of years ago, and you can find that just by Googling on YouTube and looking for myositis exercise. A lot of those exercises focus on those muscle groups that we said are really oftentimes involved, including kind of the shoulder areas and kind of the thigh areas. But again, it needs to be customized, so you really need to talk to your doctor about that. Okay, so as promised, I wanted to make sure that, did a little bit of background, but spent most of the time talking with you guys. So, that's what I had to say in terms of slides. What questions would you guys like to talk about?
Thank you. Thank you, Prateek, for that great presentation. There's been great chat going on amongst the audience. And so I'm going to try and go through the chat and find the questions that are targeted for you. And just to let folks
I'm
know,
so
if I
sorry,
miss your question,
Debbie.
yeah,
Debbie, you don't
yeah,
need to monitor the chat. Your questions are in
okay.
the Q&A box, and
You and got it.
that's where the
Oh,
questions are supposed to be. Linda will possibly have taken the questions that ended up in the chat and put them in the
wonderful.
Q&A. So
Okay, I'm
you
going
can
to
go
stop
ahead and
looking at
just
the
focus on
chat
that.
because
Thanks.
Very cool.
thank you. I thank you, Rachel. That makes it so much easier for me to find the questions.
Cool.
Um, uh, and so I'll go through and pick out some questions. We'll get through as many as we can.
Sure.
Yeah, go ahead.
Oh, no, no worries. It looks like,
Okay.
one of the questions is that a couple of people have asked is, does necrotizing myositis go into remission? And so that's a really, really great question. And it's hard because when we talk about it from a science standpoint, the question is, what does remission mean? And, we have a vague idea of what it means in terms of, you don't have a lot of disease activity. And the question is, well, are we talking about remission, meaning you have no disease activity or little disease activity, but you're still taking medications? Does it mean that you have little disease activity because it's really controlled with the medications? And both of those things are kind of subtly different. I would say that, in general, and obviously everyone's a little bit different, but in general, most people with immune-mediated necrotizing myositis and many kinds of myositis tend to not be able to come off of medications completely. And they typically need to have some type of treatment for the long haul, if not indefinitely. So there are a couple of things to that. Number one is that that's not everybody, and there are rare cases where I've seen that ends up happening. And then number two, that meaning that you have some medications doesn't necessarily mean that you're going to be on exactly what you started with, or that you should necessarily be exactly on what you started with. Again, I sometimes go back to that analogy of the building on fire. Well, how many fire trucks do you need really depends on how big the fire is. And over time, the better controlled someone's autoimmune myositis is, the better controlled it tends to be. And as the fire gets better and better controlled, it kind of stays under control longer. Sometimes you're able to send some of those fire trucks home, or kind of be able to switch to other things that might be able to keep it under control, that evolves over time. So I would say that it's important to realize that the question is not necessarily, will my myositis end up going away by itself? And it may not do that, but can my myositis be controlled, or can it be treated? And I think the answer to that is a resounding yes. The follow-up question to that is, how bad is my myositis going to be? Because people always ask that. And I think that that's one of the frustrating things for a lot of people, is that everyone's an individual. And so by example, I've had some people that were really young, great shape. I have one patient that's an was an NCAA basketball player on a full scholarship. She went from that to being bedbound over the course of 3 weeks. She had really aggressive disease. And even a couple of years later, and she's on a pretty complicated regimen, but she's doing a little bit better. And we still always have to kind of watch her because she tends to flare a little bit often. The flip side is I have someone that's almost the same exact story, that honestly, we were able to get them under control pretty well on a pretty similar initial regimen, and he's on pretty minimal medications in the long haul. And he's, comes and checks in with me every 3-4 months. And we make sure things are going okay. So I think that it's really kind of frustrating, because you're right that many people with INMN tend to have a little bit more aggressive than some of the other myositis if you're talking about the group as a whole, but everyone's an individual. And so there are definitely people that are under well control, and there are other people that have had worse luck, and it's been harder to control their disease.
Okay. I'm trying to.
Do you want me to pick out some questions that seem like
Sure,
they're
and
a common theme?
I'll look for ones that haven't been answered.
No worries. So one question is, how did I get this disease? I've never been on statins before. I've never seen a statin and things like that. And you're absolutely right that, it does seem like there is a fair number of patients, especially with the anti-HMGCR type of myositis, that have been on statins or have seen statins in the past. But there are definitely the opposite, where there are people that have never seen a statin. Sometimes those can be because of patients that have been exposed to quote unquote natural statins. And so, I have had reports of patients that have taken like mushroom supplements or red yeast rice that contain a natural statin, and that was their triggering. But you're absolutely right that depending on the studies that you read, somewhere in the neighborhood of 5 to 30% of patients have never seen a statin, and we don't have an identifiable source. And I think it's really, really frustrating, both for patients and for doctors, to kind of not be able to point to something and say, aha, this is what we could have changed, or things like that. But if I can offer unsolicited advice, the flip side is, the good news is, knowing whether or not it was statin induced or not statin induced doesn't necessarily affect the intensity of the disease. It doesn't necessarily affect how we would approach treating it. And so from that standpoint, it does seem that even if we can't identify a trigger, that it is something that we can help deal with effectively. And so that's really important to keep in mind. And even if you've never seen a statin before, typically that rule applies that most patients that have immune-mediated necrotizing myositis shouldn't be on statins in the future, with kind of a couple of rare exceptions or common exceptions. So that is one thing to just try and keep out.
I see questions about something. What are the most promising things you see on the horizon for treatment?
Great question. So if I look at the situation of the glass half full, part of the reason that I ended up really enjoying helping take care of patients with myositis was, as a fellow, kind of seeing some patients that I had interacted with, and it just was really gratifying to me as a physician to be able to try and help them with their myositis. And so that was kind of where I originally started back in fellowship. And what's been super exciting is that I ended up, serendipity-wise, coming into myositis as a really exciting time for the field when we think about the science. Over the last 5-10 years, like I said, it's been an explosion of kind of in terms of how much we understand about myositis and how much we're able to kind of think about it in a more rational or more sophisticated way. That doesn't mean that we know everything, and it doesn't mean that there's not gobs of stuff that we really have a need for better understanding or better options for. Kind of a revolutionary time, if you will, for patients with myositis. The other component of that is that, especially over the last 5-10 years, there's been an explosion in the amount of doing trials for both new and repurposed medications or other treatments for myositis. And before, it used to be kind of a little bit more of a neglected autoimmune disease, but I think it's really kind of coming into prominence, sort of like, when we talk about patients that have lupus or rheumatoid arthritis. And there are a lot of companies that are out there that are suddenly interested. And part of that has to do with work like people like you guys and people like groups like the TMA, in terms of advocating and actually making sure people are there. I'll make a small side plug for the fact that there are kind of some consortiums, research consortiums, including the Myositis Clinical Trials Consortium that's gotten started recently and really kind of expanding out, including colleagues in Europe, like the iMyos group. And all of those guys all of us are trying to come together to really talk about this. So there are a couple of medications that are in general being explored, and in those clinical trials, one of the things that you had asked about. So one of those medications include these class of medicines called JAK inhibitors, and we've used them for rheumatoid arthritis, and they come in a bunch of different flavors, and there are subtypes or things like that, but they have shown promise for other types of myositis. And we have used them off-label for things like immune-mediated necrotizing myositis. And so there's hope that we'll be able to expand out that class of medicines or that group of medicines. There's also this idea of kind of going back to repurposed medicines in terms of some of the medicines we use for rheumatoid arthritis or lupus, and even also exploring and saying, all right, well, we think IVIG is effective based off of our experience and kind of retrospective studies, meaning looking back in time and things like that, but how effective is it? What's the right dose? Things like that. And so some of the trials that are out there kind of starting to be designed or working are trying to quantify those kind of questions as well. There were a couple of questions in the chat as well about CAR T therapy. CAR T is spelled CAR hyphen T, and there's other flavors of things that go along the same lines. But basically, the big picture is that CAR T is a technology that's been used in cancer treatment for a while now, where they actually end up taking someone's immune cells and kind of isolating a certain part of their immune system called T cells, or in some times they use these things called NK cells or other cells, and they train them to actually recognize a certain target. And so in cancer therapy, they train them to try and recognize that particular person's cancer cells, and then they infuse them back and try and have them be a more targeted type of an inflammation and treatment. And so back when I was a fellow, about like 10 years ago or so now, they actually started exploring the idea, could we use this for autoimmune diseases? And they started with things like bullous skin disease. Over the last couple of years, there were actually some reports from some German groups and other groups that actually said, hey, listen, we tried this in some of our patients with really hard to treat myositis or lupus, and it looks like in a lot of those patients, it really, really helped out. And it really is exciting because a lot of those patients were refractory to other treatments. Now they're doing much better or even be able to come off medications. So there's been an explosion in the number of people that are exploring this type of technology and different variations of this technology. And I think that it's very much an experimental type of a treatment right now, but there are clinical trials that are out there in terms of phase 2 studies looking at trying to quantify the efficacy of this, trying to say, all right, well, the preliminary pilot studies look really hopeful and promising. Is this something else that would be helpful for our patients? And so I think that that's something that you'll hear a lot more about over the next couple of years.
There's, thank you. There's a number of questions about more about exercise and regeneration of muscle. Someone is has moderate exercises triggering more severe flares and weight loss or muscle loss, and another one about how does the muscles regenerate, and is there complete degeneration of some muscle cells, and how do you regenerate others? And as you answer that, I also want to put a plug in again, and because there's a number of questions about exercise and where you find exercises. So YouTube, Googling exercise for myositis, and there's some great videos on home exercise.
So those are all really great questions. And I think that, one of the themes that I think it really underlines is this idea is that everyone's an individual and everyone really needs to talk with their care team to kind of try and design a customized plan for them. And sometimes that includes including a physiatrist or a physical medicine rehab doctor, in addition to the therapist or the other people, to try and help create a customized type of a regimen plan for those type of things. In general, and again, talking from a 10,000 foot view, because it's really hard to answer individual questions when we have a big group like this. But in general, when you think about back to that slide I showed you, where it was kind of all those little muscle fibers kind of grouped together, when you have necrosis of one of those muscle fibers, oftentimes it can die away, but you can have both hypertrophy, meaning some of those other muscle fibers can get bigger to try and make up for that. So you can see that when people are going, and for instance, if you don't have myositis, you start lifting weight over time, your muscles get bigger. And part of that is because those muscle fibers have hypertrophied and gotten bigger and stronger. And sometimes you can also, unlike other tissue, muscle has the ability to generate some new fibers, and you can actually grow new fibers and things like that. That said, just like other tissues, you can also get scar tissue, and we call that fatty atrophy sometimes, because when you look at it underneath the microscope, there's these areas that kind of have been replaced by fat tissue and things of that nature. And so kind of it's a little bit of a balancing game in terms of controlling the inflammation, because the longer the inflammation goes, the more intense it is, the more likelihood that there's going to be some scar area that's not necessarily going to be healed. And then also kind of coming up with the degeneration and kind of the deconditioning, and trying to make those muscle fibers that are there a little bit bigger, and also trying to help regenerate a new thing, and kind of where that balance ends up doing and how much of a recovery that you end up having. Again, it really depends on the particular situation, including how bad is the inflammation, how long has it been going on for, things of that nature. I think in general, when I see people, I try to be really honest with them and tell them that, listen, I don't know how much recovery you're going to have. We're going to work to try and get you as close to where you were before all of this ended up starting. And we'll work and kind of try to figure out how we can get that between the combination of the things that we will. There are a lot of people that end up not achieving that, and they end up kind of falling a little bit short of that. But again, the hope is to try and get you as close to where you were when things started as it can be. And I think the flip side of that is that the general rule is that most people have a return to a really good quality of life with INMM. Obviously, there are patients that need adaptive equipment and other things and kind of accommodations to make that happen.
Great, thank you. One question that popped up to the end, and I'll add to it with my own question. Have you treated someone with NAM that also has diabetes? And adding on to that, I'll say that I, in particular, was on Mounjaro because of diabetes, and at first attributed muscle wasting and weakness to that. My question on this: if you have diabetes, are you safe to take those drugs again, or what? Yeah, or is it complicated because they could have some muscle loss with the use of the drugs?
No, that's a really great question. That kind of, I think, goes back to that theme we had talked about in terms of what's the best medication for INMN. And again, that really kind of depends on the situation in terms of not just do you have diabetes and your comorbidities, but how well controlled are they, and how responsive are you to certain medications? How responsive are you to the side effects of other medications? In general, one of the big reasons that we don't like using steroids more than we have to is because for most people, they can have the risk of raising blood sugar and or blood pressure amongst their other side effects. And that especially goes for people that have labile or hard to control diabetes. And so, sometimes there are situations where we either will, say that the pros of using those steroids aren't worth the side effects or aren't able to use the side effects. We need to adjust what our typical cookbook recipe is for that particular person. There have been situations in terms of where we've treated people without the steroids and kind of use some of these other medications. And again, just like any medicine, there's always pros to taking a medicine. There's always downsides. And same thing with some of these other medicines we use in autoimmune disease, that some of them do cause some comorbidities to get worse, or at least have the potential to make them worse in and of themselves. The second part of your question is, well, what about my other medications? Great, thank you for focusing on the myositis, but hey, I'm a whole person. I have all this other stuff going on as well. And I think that that's, again, really important because it really emphasizes how individual this type of thing is. The insider joke, I suppose, if you will, that we talk about is if you've seen 10 people with myositis, you've seen 10 people with myositis. And so you do have some, kind of themes that come across, but again, it's very much a tailored type of situation. We do know that some medications, including some diabetes medicines or things like that, can have the potential for having side effects of inflaming muscles or things like that. So oftentimes, if someone does have diabetes, we'll kind of be working with their other physicians or whoever's managing their diabetes to say, all right, well, they were on this medicine. Can we avoid this, or can we avoid these classes of medicines or things like that? It's been really exciting to see some of these newer medicines like the GLP-1 inhibitors, things like that, like Mounjaro and things like that. I think it's a little bit hard because the newer the medicine, the less experience that we have with it. Typically, in a lot of these clinical trials, when you're looking at medicines, they'll have what's called inclusion and exclusion criteria, meaning that, like, listen, these are the people that we say think are safe and okay to be in the study, and these are people we don't think are okay to be in the study. And historically, oftentimes, inclusion criteria have included patients that have had autoimmune disease, including myositis. And so it's really hard sometimes to know just from those clinical trials that may have led to FDA approval, how does it work in this particular population, things like that. So when it comes specifically to things like Mounjaro, my personal opinion is I don't think that we have enough information to make kind of big generalizations and blanket statements about that. But given how widely used those medicines are becoming and how popular those medicines are, I think it's definitely an area of interest that we're trying to learn more about, kind of trying to do some more research into and kind of see what the real world experience has been like.
Great, thank you. Well, I'm going to try the real world experience and try doing it again and see what happens. But along those lines, a great, and it's maybe getting close to our last question. If your CK levels are back down to normal and you're getting regular treatment, how often should you be tested for your CK levels? And it would more frequent, than every few months, or is it safe to drop it back to not testing it very often? What's your thoughts on that?
It's a really good question. I think it kind of, again, goes back to, if we're talking about big picture themes, I think one of the biggest themes and one of the things that I have the hardest time trying to get people to appreciate sometimes is that I want questions. Like, honestly, I don't want to make decisions in isolation, because it's supposed to be a two-way street between you and your physician, and kind of them giving you feedback and you giving them feedback and things like that. So, in terms of what's the ideal time or what's kind of the general recipe or things like that, it's a little bit hard to say for any particular person. But in general, typically the more uncontrolled someone is, slash the more they're on newer medications and we're trying to fine tune and tweak their regimen, the more closely we'll need to follow markers of their disease activity. And what are markers of disease activity? In most patients, it's physical exam and talking to them and actually seeing how they're doing in their symptoms. Oftentimes, we'll be monitoring things like lab work, like CK levels, both for looking at disease activity as well as looking for things like as well as looking for things like medication toxicity or things like that. And sometimes we may use those other tools in our toolkit, including sometimes I'll say, listen, I'm not sure. I do think that the information that an MRI or an EMG would give us would be helpful for trying to figure out how active your disease is. And what I teach the med students is, what's the if then else plan? Because you can kind of guess and say, all right, well, if I do this test and it shows me this, then we're going to do this. Or if it shows me this, then I think we should do this. And that kind of planning ahead and kind of saying, what's the utility of these different tools? So in general, those are kind of the ways that we approach it. I think that the other kind of insider caveat that I would give people is, when I teach the med students, is that there's no such thing as a normal CK. So when you look at those lab values, for most of those lab values, when you look at it, it doesn't say normal range, it says reference range. And reference range says that, hey, listen, for most of the people in our particular lab that ends up getting this blood work done, this is where most normal people, or people that don't have this issue, fall in terms of the thing. And that reference range gives you a sense of that particular test and that particular kit that they're using, what's kind of the precision and the accuracy of that test. But someone's CK level and their muscle enzyme levels in their bloodstream is really, again, an individual thing. It depends on how much muscle mass you have. So if you're someone like Arnold Schwarzenegger that has a lot of muscle mass, even if you're normal and healthy, your CK level is going to be higher than someone that's like Steve Urkel and doesn't have a lot of muscle mass. It depends on your age and your kidney function. And believe it or not, it also depends on your ethnicity. And there's been some nice work from some of my colleagues, especially when I was at University of Pennsylvania, that show that certain ethnic groups tend to have, on average, a higher CK level than other groups. And that CK level that might be, quote unquote, normal for that group as a whole may even be outside the usual reference range. And so I think that that's kind of the other tip that I would say.
Thank you. And thank you, Dr. Gandiga, for sharing your expertise with us today. Unfortunately, we are out of time. And but I do want to thank everyone for joining us, and be sure to join later today for the NM edition of Cafe Chat. It's a social hour for you and your families to visit with others who share your diagnosis. If you haven't registered already, you can register on our events calendar. And it's also a link to that was in the chat. And so it's scheduled for 4 o'clock Eastern. Yeah, 4 p.m. Eastern
5
time.
p.m.
So
Eastern.
5 p.m. Eastern. Okay.
Yes.
Correction, 5 p.m. Eastern.
Very cool.
All
And if I
right.
can just end by thanking everyone for coming up here and everyone for doing the hard work day in, day out, and kind of both dealing with their disease and educating others. And I hope that everyone will make a commitment to go out and share their experience with at least one other person and share their story so that we can all make sure that this disease doesn't continue to be neglected and that we can all move forward together. So thank you for all that you do, and thank you to the Team A as well.
Thank you, Dr. Gandiga, and thank you everyone for joining us today. It's been very good dialogue. Even the dialogue in the chat was really good. So thank you so much. And that's the end of our program.
Have a great day, guys. Happy
Thank you.
Myositis Month.